introduce our first speaker. Dr. S Scheinfeld is a former Bostonian. He went to Harvard Law School, but he's gone on to an illustrious dermatology career, and he's on the staff of Roosevelt Hospital in New York.
I'm very humbled to be here. As I was speaking with somebody earlier, I wouldn't say I could be happy, because when we're dealing with something as serious as this, I can only be humbled, and I can only be happy in a certain sense that I'm here. This is a small group. A lot of things in medicine we know are driven by pharmaceuticals. In this endeavor to try and understand kind of Degos, we have each other. And again, as the organizer kind of mentioned to me, the only thing that to give us hope is not God but each other. So hopefully this will cast some insights onto Degos disease, which again is very poorly understood. So I think that before we start to talk about some of the information about Degos and some of the difficulties, we have to have some approach towards knowledge and some kind of a hermeneutical approach for what we're going to see. So I'm going to talk about the kind of parable of the blind man and the elephant first, so just to set it up. So I don't know if people have heard of this one before, but there was a village which had a bunch of blind men in it, and they had never seen, but they had heard of this thing called an elephant, and they heard that one day there was going to be an elephant in their village, but they didn't know what that was. So they figured that they would go and find out and see what an elephant was. Although they couldn't see it, that they would feel it and use their tactile senses to come to some kind of a conclusion. So they all went to where the elephant was and they touched it. However, each of them had a different view of what the elephant was. One said that it was a pillar because he touched its leg. One said it's a rope because he touched the tail. One said he thinks it's a thick tree branch because it touched the trunk. The fourth one touched the ear, thought it was a fan. The fifth one thought it was a wall. And the last one thought it was a solid pipe. And this is, in a certain sense, a conundrum that we're in Degos disease. Because in different specialties, we see things differently. The dermatologist sees the skin. The rheumatologist sees the bones. The neuroradiologist might see the brain, and we see things differently, and it's very hard to put together a picture altogether of what the elephant is, or frankly, what Degos is. In the case of the blind men, they have a deus ex machina, because a wise man happens to wander by, and he asks them why it is that they're arguing over what the elephant is. And they say, we can't decide. We think it's many things. And he says, you're all right. And in a certain sense, when we look at the problem of Degos, we have to understand there are lots of aspects to it and lots of data. And for the most part, what we have now are really no knots. We have a lot of loose ends. And each of us sees those loose ends differently, draws different types of conclusions. And I would like to bring forward some of those loose ends to try and cast them in a new light, again, to try and give some insight or to give you a possibility of some insight into the situation. Now, we're looking here, let's say, at 6 blind men, so I decided to take 6 people who've commented on Degos. Maybe people here know Bernie Ackerman. He has many people who write papers with him. He thinks he's convinced that Degos is simply lupus. I might say I'm not sure what lupus is, but he thinks that Degos and lupus, that they're the same. That's fine. I was talking about this presentation with Bob Phelps, who's the head of dermatopathology at Mount Sinai in New York City. He said, I think that this is phospholipid syndrome just without the antibodies. Interesting way of looking at it. I have argued in some things that I've written that it's a state of dysregulation involving systems that we don't really understand. Well, that's fine, but that doesn't really give us insight as to what to do next. A fellow by the name of Burroughs said it was a multi-system vasculopathy. But frankly speaking, there are other diseases that are multi-system vasculopathies, and that doesn't tell us what Degos is. High, in a paper in the Journal of the American Academy of Dermatology, said it's an endpoint and not a disease. Well, cold comfort, one way of looking at it. And lastly, kind of trivial, perhaps kind of most truthful, said it was a rare disease of unknown cause. Saying nothing, but at least admitting his lack of knowledge. And finally, something which, again, the people who are patients here in the audience probably don't know, is that there is a database of genetic diseases. And the people who have made up this database have said that Degos falls, at least some part of Degos falls as a genetic disease. Although they don't know what the gene is, it still has a number in this thing called OMIM, which is the online Mendelian inheritance something, OMIM. So all these people have different kinds of perceptions. All blind men, all looking to understand things which are hard to understand, not being able to see, but being able to interpret at least some of the facts. So let's go ahead and ponder that out. And I'm going to pose 6 kind of conundrums involved with Degos disease. But let's set up the problem first. Well, it's rare. And one reason why we're here today is because we need more patients. When I was in medical school and I went to Yale, somebody once came to give a lecture on pheochromocytoma. So somebody in the audience said, how many cases have you seen? He said 30. That's a world expert. I would say that if there was a psychiatrist who saw 30 schizophrenics or a dermatologist who saw 30 acne patients, they would not cast themselves in the world of expert. I've seen 6 cases of Degos, and that brings me here today. We need to have the material to push forward because we can't find patterns when it's so rare. We don't know what the factor is. What is it? We see the histology, but why is it all over? Don't know that. Therapy, ineffective. We've heard about the nicotine patches, we've heard about aspirin, we've heard about this or that. Frankly speaking, nothing works in my hands, and in the severe cases of systemic Degos, nothing works. And we had a patient, which I wrote up too, they gave him everything, every kind of antiviral, every immunosuppressive, and every anticoagulant, and nothing was effective. Lastly, and really, at least, from almost an intellectual standpoint, it's almost like a Zen kind of a puzzle. What is cutaneous Degos disease? How is it that one disease can be so benign in the skin and so malignant in the body? And we'll talk about the fact that there are actually analogs of that, and maybe that'll help us. That I always, when I was in medical school, I called into question the existence of diseases which were syndromes, which had different types of criteria. I know that other people are going to discuss this. This just gives some of the things which are attached to kind of Degos diseases, that it is a vasculopathy or a vasculitis involving small and medium caliber vessels. In the skin, it has red bumps that turn into porcelain white papules. There's a systemic variant that gets into the GI tract and the brain and the organs, which causes bleeding and kills. Lots of causes have been positive, and yet treatment doesn't seem to work. This just sets up. Let's go on with the conundrums. This I just kind of put out there because we've talked about familial kind of Degos disease, 10 different reports in the literature. We don't know what they mean. I'm going to talk about that more this evening. But I want to put this up there because I know there are people in the audience, and the key question that patients have is my brother going to get it? Is my son going to get it? And the answer is we don't know, and we don't know what the significance of this is. I would say that in 1850, if you went to London and you found a family with tuberculosis, the child would have it, the son would have it, and the grandmother would have it. They didn't know what tuberculosis was. They might say that that's a genetic disease. But we don't know, and I can't give any kind of definiteness, but this is the data in the literature, and this will be available to you when you look for it. So let's look at conundrum number 1, coagulation. Now, for the people who are doctors in the audience, that they remember this from their first year of medical school, this has been kind of solid in the literature for a long time. That clotting involves 2 different kind of pathways, an intrinsic pathway and an extrinsic pathway that goes down. Eventually, it interacts with the platelets, and there is clotting. There are feedback mechanisms, which we can see here, which are anti-kind of clotting and modulate clotting, because everything in the body is fantastically designed to have feedback mechanisms. So this is clotting, as we know it. But the question is, do we really know everything about clotting? I'll tell you that I open up the kind of New England Journal or Nature or Science every month, and there's a new immune cell, that there's a new receptor, that there's a new system. In genetics, now they're speaking about this thing called epigenetics, in which more complex organizations exist of simpler systems. Are we missing something in the clotting system? Is there another pathway that we just don't see? I don't know. We would probably say no, but the bottom line is that new ways of seeing things and new systems are being discovered all the time. I would give you the example of prions, which when they came out, very controversial, that prions are this protein-based type of a disease vector. People said it's impossible. Everything has to come from DNA and RNA. Well, guess again, that there's more in heaven and earth than is kind of dreamt of in our paradigm of scientific investigation. So something to think about. But how about feedback mechanisms? Is it possible that there are feedback mechanisms that are going between the pathways that we don't really see? And these are my arrows here, which didn't come out all that well. But that somehow are connecting these pathways up here. And the Degos is basically a failure to connect. Basically that the ball is being dropped And as a result of that, there's a clotting problem. In medicine, it's very hard to pull apart a mechanical problem and an inflammatory problem, because mechanical problems generate inflammatory responses. An example of this is dry skin. Well, dry skin is a mechanical problem. The skin is dry. The problem is the way that the body reacts to that is to try and repair it, and that involves inflammation. What comes first? We don't know. So somehow, perhaps there are these feedback mechanisms that we're unaware of, maybe more likely than a third pathway. And what about the endothelial cell? Because we talk plenty about kind of clotting kind of pathways, but the endothelial cell seems to be, seems to just be like a pretty simple cell. It's a very thin cell. It kind of lines kind of blood vessels. And we can see it here. Doesn't seem to be all that much. But again, do we really know what's going on in the endothelial cell? What is the crosstalk between the coagulation system, between the platelets, between the immune system and the endothelial cell? Now look, I'm not saying things that you haven't already heard of, but I'm saying, think about it. Is there some relationship that we don't see? And again, there are many things that the endothelial cell is involved in: angiogenesis, blood pressure regulation, hemostasis, and such. But again, why is it that the endothelial cell is not somehow put on that chart of the clotting pathway? Should it really be there? Does it have some way of interacting? Think. Look for connection. More functions. Dysfunction of the endothelial cell. This is obviously a German cartoon. Lots of problems. Lots of things going on in the endothelial cell that people have taken a look at, but not that much when we think about clotting or about Degos. People have discussed this, and we are going to see that electron micrograms have been done of the endothelial cell, but its role in health and disease probably is not fully understood. And maybe, just maybe, it's the key cell in Degos. And maybe, just maybe, its interaction with the clotting system is the key thing in Degos. And some mechanical interaction rather than an interaction which can be abolished just with steroids. So maybe instead of looking for some kind of a factor, maybe there's some alteration of the endothelial cells. People have looked for it, but maybe there's still more to see. Are we missing some interaction? I can't emphasize that enough. The bottom line is, the body does a trillion operations a day, and all of us walk around. There has to be a lot of crosstalk. We don't hear all the crosstalk. Where is the error in translation? Conundrum 2. Well, look, if you read through the literature, you read about these so-called viral-like inclusions in Degos disease. Frankly, this is not a dominant feature of lupus as far as I know. In Degos it is. Now, of course, I mentioned this actually to David Silvers, who's the head of dermatopathology at Columbia, and he said, look, Noah, in the 1970s, everything had like like inclusions, that they did a lot of EM work at that time, and none of it really turned into anything. But in the 1960s, they had the EM, and they turned it on the cells of Degos, and they found these inclusions. In the 1970s, they still found these inclusions. They never found any virus, but they found the inclusions. They even found the inclusion in fibroblasts, okay? So something which, again, if you read through all the papers, you see it's not just the endothelial cells which apparently have these inclusions, but both fibroblasts in this paper, and then we'll see one where there are histiocytes. A histiocyte is an activated tissue macrophage. So basically, that's what it is. It's a macrophage. So again, histiocytes have these inclusions also. Still finding them in the 1980s, saying it's nonspecific. I don't know. Most diseases don't seem to have these, at least when they look for them. I mean, I'm not a rheumatologist. Are these found in lupus commonly?
Well, if you look at lupus nephritis, in the membranous form, there are these, Matthew maybe can talk about this a little bit more.
Classic places are lupus nephritis, the HIV-associated nephritis syndrome, endothelial cells in muscle in dermatomyositis. And the best suggestion is that they're related to alpha interferon levels, because you can induce them in cells in culture. And in all of those settings, there's no evidence that they actually have associated with viral genomes, no matter what you do.
I mean, that's an important thing, because the thing is that when you feel sick from ague, from the flu, it is not the flu that is making you sick. It is the interferon. So the interferon you know, in a certain sense, that the virus is external and disease is totally kind of caused kind of by you to some extent when you think about it. So it could be the interferon. But what is interferon doing in Degos disease? I don't know.
I just throw in one other thought, which is
Yeah.
in rheumatoid arthritis, there's been a lot of interest in human endogenous retroviruses and whether they form some structure inside cells. They clearly get expressed. So when you look at cells in these patients,
I think that that's a crucial thing. And our understanding of viruses and human disease and human evolution is not well understood. I mean, again, that there were people who got millions of dollars from the NIH, and then again it was two Chinese researchers with $25,000 on one bench who found out it was herpes virus 8 that caused Kaposi's sarcoma. There could be whole families of viruses which we don't recognize and effects on human cells that we don't know. But we do see these inclusions, and it's interesting to me that it's really linked, I guess, to some people it's linked to interferon expression. But again, that's interesting, but for Degos, what does it tell us? More of them in the 1990s. However, they went to look for the virus, and they've looked for the virus, and they never find a virus. So maybe it's just an echo of interferon. No paramyxovirus, 2000. And frankly, if it is a virus, and it is the cell responding to a virus with interferon, it must be very rare, or at least it's very rarely pathogenic. Don't know. Something to think about. But we know that we can find viruses. So in my lifetime, since I graduated from medical school, they found that. I mean, people were really trying, and yet it was just a virus. That's it. No magic. Maybe it's not a virus at all. Perhaps it's just a disease of endothelial cells, which somehow, I guess, is involved with the production of interferon. Something to think about. Conundrum 3. Well, we all know about Degos disease, for those people who are experts on it, that it causes these porcelain white lesions. And again, there are certain things that dermatology residents know. Among them, that a hybrinoma has mulberry cells, that Degos disease has white atrophic lesions. They've never seen those diseases in real life, but those pieces of trivia seem to lodge into their mind in their first month of training. But there are a lot of other diseases which do have white atrophic macules as well, although none of them really exactly the same as Degos. So the most common one by far is so-called atrophy blanche, which I guess that as we kind of understand this kind of more and more, is a sequela of so-called livedoid vasculopathy. And livedoid vasculopathy, as we look at it and as we describe more and more of the clotting problems, we see it's due to problems with factor V Leiden or platelets or antithrombin 3 or all kinds of things that can cause kind of clotting. Although the thing that I find to be very odd, and I'm going to talk about this, is that despite the fact that all these diseases, and we'll see a couple more that cause like white atrophic lesions, why is it that they don't look like the lesions in Degos disease? In Degos, they're always like kind of like round or oval. In atrophy blanche, as any dermatology resident could tell you, that they're stellate. That they're stellate, always stellate. And again, all these diseases, and we're going to see another one called lichen sclerosis erythrophicus. First they're red, I guess because there's inflammation, and then they turn white. Interesting, because most diseases in dermatology turn red, but only a very few of them turn white and atrophic. Why is that? What's the profile of interleukins? What's the cause? Is it an endpoint, or is it part of the propagation of the disease? I just want you to think about that, because unfortunately I'm not going to have that many answers for you at the end of the day. Again, atrophy blanche starts as livedoid vasculopathy, and it's due to coagulopathy. So in 2006, in the biggest kind of paper on the subject, they looked at like 45 patients who they had biopsied. I'll tell you, this is a pain to biopsy because the patients always don't heal well, and then they don't like you. But I do a lot of biopsies, so I found out. So basically, that they kind of went through it, and they found all these things. Factor V Leiden, which was discovered when I was in medical school, problems with protein C and protein S and prothrombin and all this. The thing about atrophy blanche is that for the most part, we know it's a coagulopathy, and we know that there are factors involved, and we find the factors. In Degos, we don't find a factor. Why is that? Why is it that this disease really is almost like mechanistic? Fine, there are clotting problems, and there's atrophy blanche. Why is it in Degos that we don't find this? Not clear. And basically, another thing about atrophy blanche and livedoid vasculitis is that they affect the legs. You never see it on the penis. You never see it on the back. I mean, in a peculiar fashion that we're going to talk in a second, that Degos and this other disease called lichen sclerosus don't mind affecting the kind of genitalia. And this disease never does. There are differences in blood vessels which probably exist which we don't know about. I'm going to talk more about that. Fine. Lichen sclerosus atrophicis, really more of a dermatology disease. It has a bunch of other names, you know, and in the gobbledygook of dermatology textbooks, it's a chronic inflammatory dermatosis, like all the other chronic inflammatory dermatoses. Again, like Degos and even like atrophy blanche, it starts as redness, and then it turns into these white atrophic plaques. It likes the penis most, and it likes the vagina most. Why is that? It can occur elsewhere. Again, here's a picture. It has some other names as also. It also can overlap with another disease that's called morphia. We'll talk more about that. So here I put onto a chart all these white atrophic diseases, and maybe I should have put morphia also. I mean, I have never seen a case of Degos on somebody's cheeks. Has anybody seen a case of Degos on the cheeks? Why? If Degos is lupus, lupus loves the cheeks. All my lupus patients, you know, they have redness on their cheeks or something, or, you know, it's really hard to get your mind around it. Atrophy blanche, usually on the legs, and then lichen sclerosus, again, likes pretty much the same places that Degos does. They also don't like the palms and soles. And the shape, of course, of all these white atrophic diseases is different. In the case of Degos, it's usually kind of round or oval. With atrophy blanche, it's stellate. And with lichen sclerosus, you see it's like a bunch of interconnected rings, kind of like the Olympic symbol or polymorphous. That Degos, well, in its pure form, it has no associations. We know that half of cases will overlap with something else. Atrophy blanche, we actually know exactly what the cause is. And LSNA, well, it's isolated. It doesn't have any factor. Sometimes it overlaps with morphia and scleroderma. Again, I just point this out to you. I actually was showing this slide to some of the residents at St. Luke's, and they pointed out for the first time that there's crust here. And it's interesting because I went back and I looked at all the pictures of Degos, and there are some cases where, like, there are kind of crusts on them. We'll actually see another one, I think, in one of my presentations of a case of overlap of scleroderma. I'd always thought it was just red, but this is a patient who I reported with a resident in the Journal of the National Medical Association, a 35-year-old Hispanic guy who had the systemic kind, and despite every intervention, passed away. You know, people never think of this disease called LSNA as having a vascular pathology, and yet they think of Degos as having a vascular pathology. I just put out there that maybe LSNA and Degos have more in common than we know. And the lupus link. So we will always hear people who basically say lupus is everything. I mean, that lupus is, you know, is so broad, maybe it encompasses kind of Degos as well. Certainly, there are overlap cases, but to say that they're all lupus might be missing the point. So again, case from 1987 that basically, you know, kind of described Degos-like lesions in a patient who had lupus. Some more cases of Degos-like lesions in patients who have lupus. Cases of dermatomyositis, again, and again, but I've also noted those viral-like inclusions in dermatomyositis in these Degos-like lesions. I actually was discussing that with Cynthia Magro, and she mentioned that. She's the dermatopathologist now at Cornell. An overlap of scleroderma and Degos. Rheumatoid arthritis and Degos. So clearly, when we deal with these conditions which have broad levels of dysfunction, and when we look at collagen vascular disease, they affect many organs in many ways. To me, it's unsurprising that a few of them have Degos. But there are two cases of Degos. There are just thousands of lupus and dermatomyositis. I mean, in my collection, I must have 20 pictures of dermatomyositis, and I've seen all kinds. Probably not the same things. but there are a few overlaps which are reported. And again, people can go ahead and decide which way that tilts them. Interestingly, I want to look at therapy, and again, if somebody has lupus, you give them enough steroids, at least temporarily, they tend to get better, usually. So with dermatomyositis rheumatoid arthritis, of course, with scleroderma, and it shares this feature with Degos, when you really have the kind of progressive scleroderma that affects the lungs, therapy tends not to work. So in that way, maybe we should be thinking kind of more of Degos and sclerodermas overlapping, not Degos and lupus. But again, I put it out there for you experts in the audience to try and find some parallel, to find something, to try and get a handle on it, to try and find some approach towards really defining what's going on. So we've already said this. And again, that this has been published. And they've looked at the histology, and again, that this is a study from Mo Benar, and this has been echoed by kind of Ball and Ackerman, that they did kind of biopsies, and basically that it seems to them as if this is more or less lupus. Same thing. Ball, Neuberger, Ackerman, lupus and Degos are the same. Again, that they say we deem Degos disease to be analogous to lupus erythematous in the sense that it's a pathologic process involving kind of several organs. To me, it doesn't push the ball forward. Because really the presentation of lupus and Degos is different. People here who have seen systemic Degos knows it is sort of like a skier out of control going downhill. It doesn't tend to kind of wax and wane. It goes in one direction. The patients who I've seen who have had kind of bad lupus, they actually have better days. They feel better sometimes. I don't know why, maybe because they're seeing me, or maybe they're not seeing me. But that's not true in Degos. So I think that lupus and collagen vascular diseases are bundles of different types of interleukin profiles and gene expression, which is very, very polymorphous, whereas Degos probably has a much more limited range of etiologies. So I don't think that Degos is autoimmunity, since immune suppression doesn't really seem to affect it. In case of Degos where the patient was photosensitive, I don't know, maybe that's not lupus. Lack of facial lesions and these papules. So we're really left kind of wondering what the relationship is, but I think that there's enough data to say it is distinct on some level. Conundrum 5, the lessons of location. Patients ask me, why do I have a wart here? And I say, look, you think of the skin as a unitary entity. If you're in outer space and you look down at New York City, it all looks the same. When you're on every street, every block is different, every square of cement is different. The cells in your skin are educated differently. They are different. You think that they're the same, but they're not. So you have a wart in one place because the cells weren't properly educated. You don't have a wart somewhere else that there might be wart virus because they were educated and they keep the wart away. So let's get back to some of these diseases. Degos, not on the face. Lupus, we know on the face. And atrophy blanche, which is a coagulopathy, on the legs only. Does not occur anywhere else, really. Systemic, sometimes, and again, the quantity of purely cutaneous Degos is probably understated because it's just not recognized. And again, we don't know what the cause of Degos or lichen sclerosus is, and we'll talk more about location. So why is it different? Now look, I don't even know. So I'm just going to put up some ideas here. Well, there are different kinds of glands on the face and on the palms and soles than there are on other places. Maybe the hair follicle somehow affects it. Degos doesn't seem to occur in the mouth. Is there a lack of adnexal structures that's the reason for this? We don't know all the crosstalk that goes on. We need to keep an open mind as we try and figure out what is going on with the disease, why it's working the way it does, why it happens the way it does. Just to talk about facial skin very briefly. Lupus likes the face, but not the eyelids. Rosacea likes the face and eyes. Acne likes the face, but affects the back and chest. Dermatomyositis with the heliotrope rash occurs in the eyelids, and PMLE, for the most part, avoids the face. We don't have a sense for that really yet, why the skin is different. And again, it could be from left field, and when we have that insight, it'll shed some light on Degos. This, again, I can't get my mind around this problem at all. Why does Degos stay in the skin in some cases, and why does it go to the organs? Some suppressor function, I don't know. I will leave that for the other speakers. Why is cutaneous Degos, for the most part, stable? Again, not clear. Is there some difference in the endothelial cells in the skin and the organs? Is there some suppressor function? I really will leave that for other people to speculate about. It really is a conundrum. But as I'll speak in my other talk, it's also a conundrum with scleroderma and morphea, because morphea stays in the skin, whereas scleroderma also affects the internal organs. How does the body draw the line between morphea and scleroderma? How does the body draw the line between cutaneous Degos and systemic Degos? And frankly speaking, even within cutaneous Degos, this paper in the British Journal found it just occurring over here on the abdomen. Kind of peculiar. Here I just talk about the fact, does it really avoid the palms and soles? Well, it's been reported there, but was it Degos or lupus? Hard to say. Hard to say, again, because of the overlap and because lupus is so protein in its presentations. But this is my opinion. Conundrum 6, we're winding down. Treatment. You know, this disease is extraordinarily kind of peculiar in that nothing works. I mean, people talk about aspirin, that it's hard to really understand what system is involved if nothing works. Immunosuppression doesn't work. Hyping up the immune system with interferon doesn't work. Nothing seems to work. It basically has to expand our idea of the systems that are present. Because there has to be some system that can be affected. It's not magic. It's complex systems interacting continuously, and we just don't see where they stop and start. And again, we can speculate as to why this is. There's some broad sense of dysregulation. It flips a switch that can't be turned off. I don't really know. It affects some kind of a system that we're unaware of. It basically is not really a disease at all. I mean, when you're healthy, you stay healthy. Maybe this is the way you're supposed to be, in which case you can't kind of cure somebody from being how they should be. All these are speculations. What does it mean if there's no Degos factor? And we can't really find a factor yet, but that doesn't mean that there is one. That plasmapheresis, where they strain your blood, doesn't really work. IVIG doesn't work because there's nothing to really to neutralize. Immunosuppression doesn't work because it's not really involving the immune system. And even doing bone marrow ablation and transplant wouldn't accomplish anything because there's no real involvement of the blood cells, perhaps. Maybe it's something else. Maybe it's just the endothelial cells. So I'm just going to conclude on this and just say that when we look at Degos, it's hard to integrate all that's going on. I hope I brought home some of the conundrums involved with the disease, just to try and open up our minds so we can be more open to new data. And I just would emphasize that I think that the body has many complex systems that are interacting continuously. And because of a continuous interaction, we cannot see where they start and stop. As a result, it's hard to know how we can jump into the problem to try and study it. And like the blind men, you know, we all have our opinions, and we're waiting for some wisdom to come through and illustrate stuff for us. So with that, I'll end. Thank you.